Welcome to Black Health Matters. I'm Darryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
From birth, from young age up until the 80s, and at every stage, the mortality rate for men is higher than women. So much so that they wonder if maybe they ought to be an office for men's health. There's an office for women's health in the NIH, but there's not an office for men's health. But this longevity gap, which is what the article is all about in the Washington Post, emphasizes that men are dying faster than women. Of course, that's not so startling, except that it's getting worse. And so the thought is that we should be doing more about it. And I think that that's something that we need to. We're well aware of it, as we know that the men tend not to go to the doctor, and men don't tell the whole story all the time when they go to the doctors. But this longevity gap seems to be getting wider and wider, and so the article is calling our attention to the fact that we need to work even harder to make sure that men are getting to the doctor and getting their health checked, and doing all the things that promote a healthy and long quality lifespan, which appears as though that's not happening with men. So the question is, what can we do to narrow this gap between men and women and the mortality rates? The second article that I thought was alarming, but not the most alarming, I'll say that for third, is the fact that among the overdoses, the opioid overdoses, group that is growing faster is the elderly. Opioid overdoses and fatalities occurring as a consequence of these overdoses are growing faster in the elderly group, the group over 65, than in any other group, suggesting that we need to pay more attention to the problems associated with aging in the group of patients who are over 65. And it was surprising that although the younger people have a larger number of people who are having fatalities, the fastest growing group of mortality rate is in the people over 65. Then the third item that really caught my attention was a study from Europe, which was a surprise to me, that studied about 80,000 men of African descent, and 80,000 of healthy men, 60,000 healthy men, and about 20,000 with prostate cancer. And what this surprising genetic study identified was that there are prostate cancer that are found only in men of African descent. And these prostate cancers are very aggressive. And so it emphasized the importance of not only the PSA, but also the digital rectal examination in terms of making an earlier diagnosis of prostate cancer. But the thing that was remarkable was that they found 7 newly discovered variants, which are found primarily or exclusively in men of African descent. And so they are trying to put together genetic tests that will be able to identify those people, those African males who have this unusual type of prostate cancer. We already knew that prostate cancer in men was uh, different in African American males in the United States, but this points out that that men of African descent uh, not only have an increased rate of prostate cancer, they have types of cancer, prostate cancer that is only found in uh, in men of African descent. So,
Dr. Cal,
yes.
we had an article. I don't think that we brought it up though, but the article was talking about how you can do a blood test in place of doing a colonoscopy. You remember that article?
Yes, I do. And that blood test uh, has not been
Approved.
determined to remove the risk of colonoscopy. What it does, it kind of uh, gets a test that identifies whether you have cancer. But the real value of colonoscopy is finding out whether you have polyps that will later on turn into cancer. So the screening aspect of the colonoscopy is what is as important as the cancer itself, because you want to get to the polyp before it turns into cancer. And so this is a test that is being worked on and has not been FDA approved to do so. So that's a test that's in the works and may turn out to be some help in identifying cancers. But I think it does not replace the need for colonoscopy yet. And most of the value of the colonoscopy is identifying polyps before they turn into cancer, so that you can remove them and eliminate the possibility of cancer. So waiting for cancer to develop is not a good way of addressing it. I think colonoscopy may be the better way right now. And they are looking for more tests, DNA and RNA tests that identify cancers, but really keep in mind that the colonoscopy is not really to find the cancer, but is to find the polyps that
Dr. Cal,
that occur before the cancers found.
before John Buchanan comes in, I had one other question, and that is, back in the day, is it true that they would do the colonoscopies and tell you that you have some polyps, and now in the new day, they do the colonoscopy and they take the polyps out all in one fell swoop?
That's what they've always been doing, as far as I know.
Okay, John Buchanan.
Yeah, Dr. Callender, the test for the prostate cancer, that would be a blood test?
PSA. Oh yeah. Well, okay. The PSA is the one test, but they're talking about developing genetic tests that identify. Remember, you had mentioned that there's a genetic predisposition, and so they want to find the actual genetic predisposition, so that they could predict who would develop prostatic cancer or not. And that's what they are aiming at. They have not achieved it yet. That's what they're aiming at, because they now have identified 7 new genetic variants, which are found only in men of African descent, prostate cancer, men of African descent.
Yeah, that was my question. The new test, that would be a blood test.
Yes, it would be. Yeah. Okay. Yeah, would be a blood test.
And Dr. Callender, is that similar to the what is it, BRCA test that you do for the women's cancer, breast cancer, or
Yeah,
ovarian?
in some, yeah, yes.
Yeah.
Similar genetic variant.
Mhm.
I think I was surprised that this came out of Europe, because I thought most of the studies would emanate from the United States, but this is a study that it actually is in the European journals. So Any questions on any of those subjects we talked about? Any of you buy eggs?
Eggs,
Yeah, eggs.
yes.
Because I understand the price of eggs has increased significantly.
Well, see, I thought it had gone down. I bought a dozen eggs last week, picked it up, bought it because you always buy eggs. I do. And the first thing the cashier said, "Oh, eggs going down." And my dozen of eggs was $3.99. And a month or two ago, when it was really rising, I paid as much as $5. So I
Oh,
thought it was going down now.
okay. All right.
Yeah.
Yeah, all right. Okay. All right. Well, I guess if there are no more questions about those interesting developments that
One more
Uh,
question. One more
yes.
question. What are the statistics on prostate cancer in African American men? Would you say something to that 90% will have it for age 90? Is that what you're going to say?
No, I didn't say 90%. I said say close to 100%. At least probably 95% by the age of 90 to 100 are going to have either prostatic enlargement, which we call benign prostatic hypertrophy, or prostatic cancer.
Thank you.
My brother was telling me yesterday, I was talking to him. He was a little nervous. I said, "What's going on?" He said, "Well, I think I have bad news." I said, "What's your bad news?" "I think I have prostate cancer." I said, "Why do you say that? Who told you that? What's going on?" And he said something about his PSA number, which he didn't know what it was, and something else the doctor told him. But he said, "I'm supposed to have an in and out test." Is there a test that you can do?
Yeah, there's a biopsy. There's a
Mm-hmm.
biopsy that they do.
Mm-hmm. Yeah. I'm gonna have to
Yeah,
talk more with him.
that after if you have a high PSA, then the
Mm-hmm.
next test that they do is a biopsy of the prostate to find out whether the cancer is still in the prostate or whether it's outside of the prostate or whether it's moving towards to get outside of the prostate.
Okay. He wasn't sure. He
And
said a test, so maybe
that
it is
is
that.
the biopsy.
Yeah.
Then after they do the biopsy, they decide on whether it's aggressive or not, or whether it requires surgery or whether it requires radiation or chemotherapy and so forth and so on. So that definitive treatment is determined by the biopsy.
Okay. All right. Thank you.
Okay, well, those are the things that I thought I should call your attention. I'm glad that Mr. Tatum pointed out that there's some articles that we haven't had a chance to discuss that bear discussion, and we haven't been able to address some of those because we've had presentations. So if there are any of those articles that get to your attention and you want us to discuss this, just bring them up and we'll discuss them. Okay. Okay, I guess we can start with the articles we have. This is the article that promotes a lot of discussion, and I think it's interesting that, and I think it's appropriate to modernize and optimize everything. So identifying that 70 deaths linked to that is interesting, but it doesn't also recognize the fact that we performed 1 million life-saving transplants over time. And so, yes, there are problems with this, and yes, it needs to be improved. But one of the things that bothers me is that in many of these articles, they forget the fact that the number one problem in transplantation today is the shortage of donors. And so the fact that the increase in the budget is very important. But I think emphasizing only the fact that we have a network problem that is not the best it could be, I think is not recognizing that that is not the number one. We know that 17 people die every day because of the shortage of donors. And this then requires us to have a system that is optimal, and that the intent is good in terms of optimizing the system. But you want to be sure that you don't toss out the baby with the bathwater and get a system that does not improve, because we need a system that addresses the inequalities that exist in the system and improves them. And that is very important, because this affects us more than any other group, because the largest group of people on the waiting list are minorities, people like us, African Americans and Latino Hispanics. And so it's important